will bring some new lights on your practice. So you all know what is aggressive prostate cancer. It's mostly, the definition is mostly clinical, with an earlier biochemical recurrence, earlier metastatic, and castration therapy resistance. And the point is there any clue for prevention or adequate therapy for these patients? So we have three types of clues. The first one is the purely histologic grade and staging. Then molecular markers, as we talked already, like decipher, and genetic profile of this patient. We start with the histology, and this is just a reminder because you might probably know that. So the diagnosis of prostate cancer is made on a low power field on criteria and architectural criteria. So it's a loss of the normal lobular architecture. We find microgodular foci, and there is infiltration. We saw that better on that. I don't know if I can show that. Do you have a red light, you know? Yes. So you see here clearly the small glands infiltrating between the normal prostatic glands. So this is an important point, that when the tumor appears, it starts to form glands look like the normal prostate. The pathologists have some tricks to make the diagnosis of prostate. Maybe you find that on your histological reports. So this is the use of antibodies, P54, P504 and P63. So the first one, called also racemase, it's here you see that the brown color of the racemase on the tumor and not on the normal glands. And here you see the P63 and the basal cells that are conserved on normal glands and absent on the pathologic one. So the main thing in the pathological report is the Gleason scoring. And we had an evolution in the Gleason scoring since the definition made by Gleason itself in 1966. So we have two main differences, two main evolutions. The one was in 2005, and the second one, and this is one in 2005, just moved some of the histologic appearance of the cancer between grade 3 and grade 4. And then the second most very important one is the isoquantification in 2014. So just as a reminder, the Gleason 3 is a well-differentiated tumor with small glands infiltrative, with no fusion and no cribriform patterns. Here you see an illustration of a grade 3 with these small glands and always this trauma in between each glands. So this is typically grade 3. Grade 4, we have four histological appearance of the grade 4. One is the glomeruloid, the one that moved in the 2005 definition between grade 3 and grade 4. It looks like glomeruli in the kidney. Here are the fused image of grade 4, that the small glands will close one to the other one and fuse, start to fuse. Here, another aspect of the grade 4 is the poorly formed glands. So here you hardly recognize normal or pathologic glands. And the last one, the most important one, is the cribriform one, where you don't have any gland architecture, but mass of tumors with hole in it. Gleason grade 5 has no glandular differentiation, no lumen. So there are two main aspects in the grade 5. It's either isolated cells just infiltrating the tissue, or large mass of tumors infiltrating the tissue. So you see here, the more undifferentiated is the tumor, the more it is aggressive. So the ISUP decided to change the previous Gleason staging scoring, and because for two main reasons. The first one is that when you used to say to a patient you have a Gleason 6/10, the feeling of the patient was that might be aggressive tumor. That is not, you know. And the second one is the differentiation between group 2 with less than 50% of grade 4 and group 5 with more of 50% of grade 5. So on the histological report, you have to precise, of course, the percentage of grade 4 to discriminate between group 2 and group 3. Then group 4 is 4 plus 4, 3 plus 5, or 5 plus 4. That is the old Gleason score 8. And group 5 is Gleason more than 8. Okay, let's go back to the Gleason 4 grade, cribriform. So as I said, if you remember, the Gleason grade 3 is small glands with intermediate stroma between them. Then the difference between grade 3 and grade 4 fusion is that the gland grows closer and closer and fused. And in the poor differentiated Gleason 4, the glands are very difficult to recognize. Here, you don't have any glands. You have just mass of tumor with hole in it. That means that the tumor is instinctively, for the pathologist, more aggressive in the cribriform pattern than in the other form of Gleason 4 patterns. So the Gleason 4, the cribriform Gleason 4 form histology has a real impact in the disease. So it is quite rare in ESUB2, with less than 20% of ESUB2 with cribriform pattern, but it's more frequent in the Gleason ESUB3, with more than 50% in the case of cribriform pattern inside. On biopsy, presence of cribriform means that you probably have a high risk of extraprostatic extension on the prostatectomy. And on prostatectomy, the presence of cribriform pattern is linked to the shorter biochemical recurrence, to the shorter appearance of metastasis, and to a shorter disease-specific survival. Regardless, that's the point of the percentage of cribriform architecture. At least the correlation between the pathologist on cribriform recognition is moderate, I should say, not very good. You say here with the kappa, very bad. In ESUB2, the presence of cribriform as outperforming regarding the evolution of the disease concerning, comparison between the presence of cribriform, the Gleason pattern 4, and the presence of even the Gleason pattern 5 in this kind of ESUB2. So it's an important prognostic clue, the presence of cribriform pattern. A question now is on the size of the tumor on biopsies. As we saw this morning, the MRI gives relative good information concerning the size of the tumor. And what we can observe is that the dimension of the tumor on targeted biopsy is very fairly related to the size of the tumor seen on the MRI. So what I do in my pathological report is giving 3 information. The first one is the ESUB score. The second one is the length of the maximum length of tumor on the targeted biopsies with the Gleason pattern corresponding. And the third one is if ever we have sextant biopsies, that is almost always the case, give the sum of the tumor on these targeted biopsies that give an approximative information about the total volume of the tumor inside the prostate and outside the targeted biopsies. So also the MRI gives quite good information about the extraprostatic extension. And this is another point. We all know that the presence of extraprostatic extension is linked to the prognosis of prostatic cancer. So we can see here clearly that with no extraprostatic extension, with a small one, and with a large one superior to 3 millimeters. And we are also instinctively understand that if the extraprostatic extension is very small, it's different than if we have a huge extraprostatic extension. So the size of the extraprostatic extension is an important factor in the prognosis of these tumors. Now, a quick view on an unusual histologic pattern of cancer. So the common one is the acinar, as we saw, with the small gland infiltrating tumors. We have different histologic aspects that might have a prognostic impact, but are very rare tumor. This is the single ring, the pleomorphic, and the sarcomatoids that you barely never see on your histological report. But there is one that is more important and more interesting. It's the ductal adenocarcinoma. So as a pure form, the ductal carcinoma is quite rare, but it's usually associated with the acinar carcinoma. And in case of presence of ductal carcinoma, we have some clinical information that are interesting. The PSA is usually lower than in acinar carcinoma. The extraprostatic extension is quite more frequent than in classical acinar cancer. The risk of lymph node metastasis is almost the same, but the risk of visceral metastasis is almost 5 times more. And more of this, the location of these visceral metastases are unusual. You find brain, lung, and mainly brain, lung, and skin metastasis that you usually don't find in acinar carcinoma. More than this, the presence of ductal adenocarcinoma has an impact on overall survival, on biochemical recurrence. More with earlier biochemical recurrence, is the percentage of ductal adenocarcinoma is higher, especially after 50% of ductal adenocarcinoma in the prostate. And the percentage of ductal adenocarcinoma has a clear impact on overall survival if the percentage is superior to 30%. Another histological interesting kind of tumor is the intraductal carcinoma. So histologically, it's sometimes difficult to recognize because it looks like high-grade pin. And when you use the immunohistochemistry, as I said earlier, you still have a P63 layer of cells present. So the diagnosis is made because the tumor just span the anterior lumen of the gland, and the cells are very possess very markedly atypies. If you have only intraductal carcinoma and biopsies, you have to say that you have intraductal carcinoma and that you're not sure if there is any infiltrative carcinoma with it. So you need to make very early new biopsies to confirm the diagnosis of infiltrative carcinoma. If you have intraductal carcinoma with a normal acinar carcinoma, this has to be considered as a cribriform pattern, so an aggressive form of cancer. Now, a few words about the molecular insight of prostatic carcinoma that can maybe help in taking care of the aggressive prostatic carcinoma. So the first one, the TMPRSS fusion cell, has been described as present in 50% of the prostatic cancer, but it's an early event, so it has no really impact. It make together a transcription factor and a receptor of the hormones, so increase the presence of this receptor on the surface. Among this family of ERG, you have also different other type, that is ETV, ETV1, ETV4, and so on. But all these anomalies have no impact on the prognosis of the tumor. Even the mitotic index K-subset has no impact on the prognostic of this cancer. Sorry. Concerning PTIN, we will talk about a little bit more. So all these data has no clinical impact. You have also some biological information or tests that can be made. So you have here the list of the biological markers maybe can be used in the assessment of the active surveillance of taking care of the patients. Just like this test, maybe to differentiate between patients that can follow active surveillance and the patients that should not have active surveillance. In fact, this has no real clinical and daily impact also. You just put patients on active surveillance if there are 3+3, so IZIP1, or maybe a few cases of IZIP2 with very low percentage of Gleason 4. Other molecular panels can be used. Two of them are here, the PAX and the PAM50, that describe 3 types of prostatic carcinoma. Luminal A, luminal B. Luminal is very used either in breast cancer or ureteral carcinoma. These two panels have similar information. The PAX2 and the PAX1, sorry, and luminal B are the worst prognosis, with specific survival, biochemical recurrence, and metastasis impact, as you see here clearly. Continuing on these molecular panels, they have some histological correspondence, not really very good, as you see here. For instance, the ductal adenocarcinoma is in luminal A, that is considered as a good cancer. That is not what we found earlier. And the where is that? Neuroendocrine, where is the neuroendocrine? It's there. The neuroendocrine carcinoma is in the basal type of prostatic carcinoma that is, according to the PAM50, is also not a very bad cancer. But more interestingly, this molecular panel gives information about the molecular involved in the prostatic cancer. So you see here that a luminal A has an impact on TGF-beta. The basal has an impact on interleukin-6 and STAT3 pathway, and the luminal B has an impact on the presence of these three proteins are involved in the immune system, the immune response that we'll see later on with the PTEN as an importance in the prostatic cancer. So all these tests are expensive, have no real clinical impact, and need more trial to appreciate their impact on the aggressive prostatic carcinoma. Now, 2 last points. The first one is BRCA. That is a gene involved in the DNA repairs that has a great importance in prostatic carcinoma, like in breast carcinoma, because you say that family prostate cancer mainly have a mutation in the BRCA and some of other genes that are involved in the reparation of DNA. The percentage of BCR2 mutation total population with prostate cancer is about 6 to 7%. It's important point. It's present as in the primitive lesion in the beginning of the disease. So it's a primary event in the appearance of the prostate cancer. The presence of a mutation in BRCA2, that is the main gene of this family involved in prostatic carcinoma, is it is associated with higher Gleason score, with higher stage, with an either lymph node involvement, with an either risk of metastasis at the beginning of the disease. It's an important independent prognostic factor of cancer-specific survival and metastasis-free survival in prostatic localized cancer. And the germline mutation has more impact than the BRCA mutation that only present in the tumor. So patient with history family of mutation of BRCA that have the constitutional mutation of BRCA are more risky to have aggressive disease than the one that have only a mutation in the tumor. You know that the treatment against BRCA2 has an impact on the progression and overall survival of the disease, especially in patient with a mutation, of course. The effect of the medication is better in patients that have the anomaly than in the one that have not. Concerning the immune checkpoint inhibitors that I said we talked earlier, the prostate cancer is a cold tumor that when you look at the cancer prostate on a microscope, you see barely immune cells. Because the microenvironment of the cancer is poor in lymphocyte and is rich in cells that are an impact on the negative modulation of the immune response. And among that, the P10 alteration and the other molecular alteration that we saw earlier on PAM50 test, that is TGF-beta and interleukin-6 and SEMIC, have also an impact on the immune response, and they lower the immune response. We have seen that the PD-L1 expression is correlated to high risk of recurrences, but the anti-PD-L1 treatment alone has no impact on the disease, and is maybe because of this microenvironment in the prostate cancer. So the idea now is to use the anti-PD-L1, the inhibitor of checkpoint, the treatment by inhibition of checkpoint inhibitors, sorry, might be used in combination with other treatment. And this is under investigation. The last point is the deletion in gene that are used in the, sorry, just MMR and MSI, don't find the name in English, sorry. Instability, microsatellite instability, thank you. Thank you, all right. So this is a rare event in prostate cancer with less than 5% of patients with an alteration on this pathway, but it is associated with a higher grade of Gleason and higher metastatic rate and a shorter overall survival. So several trials are now under investigation to demonstrate the better efficiency of inhibitors of the inhibition of the inflammation and the microsatellite instability. So last point, how to evaluate all these elements. So the evaluation of the presence of cribriform and ductal carcinoma is easy on the slide. So you can do that easily on the slide. If you're looking for genomic profiling, this is, as I said, very expensive, but you can do that on formalin fixed in paraffin embedded tissues, or even in circulating cells if you don't have the initial histologic material. The PD-L1 is easy, appreciated on immunochemistry. It's an easy job to do. And the same for the microsatellite instability. Concerning the BRCA, the technique is more heavier, and you just can't do that with new generation sequencing. You can do this new generation sequencing on paraffin tissues or circulating cells. But if you do that on paraffin tissue, you have to choose recent tissues because the alteration of the DNA goes with the time. So you have to use tissues with less than 5 years. Otherwise, you better go on circulating cells and the element you can have on the current time of the disease. So when to test VRCA? There are two main recommendations, one made by the Philadelphia Consensus and the other one made by the ESMO. Among the families of patients with prostate cancer, the patient with a family history of early prostate cancer, the patient with a family history of breast or ovarian cancer among the sisters or mother, and a patient with Lynch syndrome family. Otherwise, you can also look for BRCA mutation in patients with metastatic disease that have no other treatment possibilities. Some recommended also the testing in the patient with active surveillance. This is the Philadelphia consensus. And with patient with DMICO3 with less than 50 years old that are supposed to be very aggressive tumor. If you look at this mutation, I said in the overall population, the mutation of BRCA is around 6%. If you test that on a patient with cancer before 50 years, you will find it in approximately 2% of the patients. If you look in patient with family history of prostatic cancer, of breast or ovarian, in almost 8%. And in patient with metastasis, it's almost the same that patient with early prostatic cancer is around 2%. And altogether, he has an history family of prostatic cancer. He has a young age and he has a metastasis. The risk of finding the BRCA mutation is almost 13%. Conclusion before lunch. So aggressive forms of prostate cancer is easy to find on histological and should be suspected if you have ISUPs more than 2, that is 3 and over. Cribriform pattern, whatever this percentage of cribriform pattern, and ductal carcinoma, especially if you have more than 30% of ductal carcinoma. But no element can yet help the urologist to predict the evolution as metastatic or androgen therapy resistance or neuroendocrine evolution of the tumor. And no markers can help in choosing adequate treatment except BRCA or MSI. But many works are in progress and future seems promising. Okay. Thank you for your attention.